This is Jasper Elena, graduate student of MS Health Informatics from the University of the Philippines, Manila. And this is for the partial fulfillment for the subject MI224, Coding, Classification, and Terminology in Medicine. This report is about international classification of impairments, disabilities, and handicaps. To give a quick background, the International Classification of Impairments, Disabilities, and Handicaps promotes a common framework and definition of disability-related issues. ICIDH was published in 1980 by the World Health Organization in Geneva. The 1980 ICIDH distinguishes three dimensions that can be studied to monitor the situation of people with disability. The first one is impairment, any loss or abnormality of psychological, physiological, or anatomical structure or function. Second is disability, any restriction or lack of ability to perform an activity in the manner or within the range considered normal for a human being. Last is handicap. This is a disadvantage for a given individual resulting from an impairment or a disability that limits or prevents the fulfillment of a role that is normal for that individual. As we can see from the timeline of ICIDH, it was in 1972 when it was initially developed and submitted to World Health Organization by Mrs. Esther Kahana of Israel. In 1973, Dr. Philip Wood of UK assimilated schemes compatible with ICD. It was also here when informal circulation of systematized terminology was introduced. 1974 saw the circulation of separate classification of impairments and handicaps, as discussed by Professor André Gossard of Paris. In the 29th World Health Assembly, the resolution WHA 29.35 was passed. This is the publication, trial purpose, supplementary classification of impairments and handicaps. It was in 1980 when ICIDH, or the International Classification of Impairments, Disabilities, and Handicaps, was published. 1993 saw the first revision of ICIDH. In 1997, this was the end of Stage 1 beta testing for ICIDH-2. The Stage 2 of beta testing was finished in December of 1998. ICIDH version 2 was released in 1999. The pre-final version of ICIDH version 2 was completed in year 2000. It was in 2001, during the 54th World Health Assembly, the endorsement of the final versions of ICIDH to the current International Classification of Functioning, Disability, and Health, or otherwise known now as ICF. We can compare the three-dimension factors between ICIDH version 1 and version 2. ICIDH have impairment, disability, and handicap, while ICIDH version 2 have impairment, activity, participation, and contextual factors involved. The World Health Organization family of international classifications provides a framework to code a wide range of information about health and uses a standardized common language permitting communication about health and healthcare across the world in various disciplines and sciences. ICD-10 provides a diagnosis, and this information is enriched by the additional information given by ICIDH-2 on functioning at body, individual, and society levels. Together, information on diagnosis plus functioning provides a broader and more meaningful picture that describes the health status of people which could be used for decision-making purposes. Two persons with the same disease can have different functional states, and two persons with the same functional state do not necessarily have the same disease. Hence, joint use enhances data quality. Use of ICIDH2 should not bypass regular diagnostic procedures for medical purposes. In other uses, ICIDH2 could be used alone. Benefits of ICIDH2. These are the aims of ICIDH2. Number 1, to provide the scientific basis for understanding and studying health and health-related states, outcomes, and determinants. Number 2, to establish a common language for describing functional states associated with health conditions in order to improve communications between healthcare workers, other sectors, and disabled people or people with disabilities. Number 3, to permit comparison of data across countries, healthcare disciplines, services, and time. Number 4, to provide a systematic coding scheme for health information systems. Disease and disability are distinct constructs which can be viewed independently. Disease is one construct and disability, in the ICIDH2 sense, is another construct. Disease and disability constructs may not always be in a predictable, one-to-one relationship since each construct has independent features. Application of ICIDH2 can be applied as a statistical tool in the collection and recording of data, as a research tool to measure outcomes, quality of life, or environmental factors, as a clinical tool in needs assessment, matching treatments with specific conditions, vocational assessment, rehabilitation, and outcome evaluation, as a social policy tool in social security planning, compensation systems, and policy design and implementation. Lastly, it can also be used as an educational tool in curriculum design and to raise awareness and undertake social actions. Since ICIDH2 is inherently a health and health-related classification, it is also used by sectors such as insurance, social security, labor, education, economics, social policy, and general legislation development, and environmental modification. ICIDH2 is useful for a broad spectrum of different applications, for example, social security, evaluation in managed healthcare, and population surveys at local, national, and international levels. It offers a conceptual framework for information that is applicable to personal healthcare, including prevention, health promotion, and the improvement of participation by removing or mitigating societal hindrances and encouraging the provision of social supports and facilitators. It is also useful for the study of healthcare systems in terms of both evaluation and policy formulation. As earlier mentioned in the timeline, in May 2001, World Health Organization approved the final version of International Classification of Functioning, Disability, and Health, otherwise known as ICF. It moved from consequences of disease to a classification of human functioning and disability. Understanding ICF. This provides a description of situations with regard to human functioning and its restrictions and serves as a framework to organize this information. It provides a structure to present the information in a meaningful, interrelated, and easily accessible way. The functioning of an individual in a specific domain reflects an interaction between the health condition and the contextual, environmental, and personal factors. There is a complex, dynamic, and often unpredictable relationship among these entities. The interactions work in two directions, as illustrated. To make simple linear inferences from one entity to another is incorrect. In example, to infer overall disability from a diagnosis, activity limitations from one or more impairments, or a participation restriction from one or more limitations. It is important to collect data on these entities independently and then explore associations between them empirically. Organization of ICF. Functioning is an umbrella term for body functions, body structures, activities, and participation. It denotes the positive aspects of the interaction between an individual and that individual's contextual factors. Disability is an umbrella term for impairments, activity limitations, and participation restrictions. It denotes the negative aspects of the interaction between an individual and that individual's contextual factors. ICF provides a framework for the description of human functioning and disability, and for the documentation, organization, and analysis of this information. ICF classifies functioning and disability, not the people themselves. Although organ level was mentioned in the 1980 version of the ICIDH, the definition of an organ is not clear. The eye and the ears are traditionally considered as organs. However, it is difficult to identify and define their boundaries, and the same is true of extremities and internal organs. Instead of an approach by organ, which implies the existence of an entity or unit within the body, ICIDH2 replaces this term with body structure. We have some definition of components of ICF. Number 1. Body functions, the physiological functions of body systems. Number 2. Body structures, the anatomical parts of the body such as organs, limbs, and their components. Impairments are problems in body function and structure such as significant deviation or loss. Activity is the execution of a task or action by an individual. Participation is the involvement in a life situation. Activity limitations, difficulties an individual may have in executing activities. Participation restrictions, problems an individual may experience in involvement in life situations. Lastly, environmental factors are the physical, social, and attitudinal environment in which people live and conduct their lives. These are either barriers to or facilitators of the person's functioning. Code format. The chapters are often subdivided into blocks of categories. The prefix D represents the activities and participation component, although the user may choose to use the more granular optional A for activities or P for participation, depending on their specific user needs. Another code format. ICF codes require the use of one or more qualifiers which denote the magnitude or severity of a problem in question. The problem refers to an impairment, limitation, restriction, or barrier when used in combination with B, S, D, or E codes, respectively. Generic qualifiers are coded as one or more numbers after the decimal point. Qualifier number 8 means not specified and is used when the information provided about the category is insufficient to guide the choice of an appropriate qualifier. Qualifier 9 means not applicable and is used when no specification can be given about that category. Coding positive and negative aspects. At the user's discretion, coding scales can be developed to capture the positive aspects of functioning. One can see the ICF coding structure. It starts with the ICF as the classification, followed by functioning and disability and contextual factors as parts. A part is then further subdivided into different components, and these components are further categorized as constructs or qualifiers, and each construct or qualifier are further narrowed down to domain and categories as different levels. Body function are coded with one qualifier that indicates the extent or magnitude of the impairment. The presence of an impairment can be identified as a matter of loss or lack, reduction, addition or excess, or deviation. Body structures are coded with three qualifiers. The first qualifier describes the extent or magnitude of the impairment. The second qualifier is used to indicate the nature of the change, and the third qualifier denotes the location of the impairment. You can see a detailed classification of the first, second, and third qualifier for body structures. Activities and participation are coded with two qualifiers. The performance qualifier, which occupies the first digit position after the decimal point, and the capacity qualifier, which occupies the second digit position after the decimal point. The code that identifies the category from the activities and participation list and the two qualifiers forms the default information matrix. The performance qualifier describes what an individual does in his or her current environment. Because the current environment brings in a social context, performance as recorded by this qualifier can also be understood as involvement in a life situation or the lived experience of people in the actual context in which they live. The capacity qualifier describes an individual's ability to execute a task or an action. This construct aims to indicate the highest probable level of functioning that a person may reach in a given domain at a given moment. To assess the full ability of the individual, one would need to have a standardized environment to neutralize the varying impacts of different environments on the ability of the individual. Third and fourth qualifiers provide users with the possibility of coding, capacity with assistance, and performance without assistance. The fifth digit position is reserved for the qualifiers that may be developed in the future, such as the qualifier for involvement or subjective satisfaction. Environmental factor acts as barrier or a facilitator. Using a decimal point alone will denote a barrier, whereas using the positive sign instead denotes a facilitator. How can ICF be used as a tool? ICF can provide a unified, standard language and framework for the description of health and health-related states. ICF can be used to share the functioning status assessment, goal, treatment plans, and interventions, as well as to monitor data with key stakeholders. Lastly, ICF is a tool that uses everyday terms to facilitate communication across services, organizations, and agencies. A sample coding for ICF based on this picture. Both patients are classified under ICD-10 as B24, otherwise known as HIV disease. But from the picture, you can also see that these two individuals are also totally different. Using the classification of ICF, we can see that the individual on the left of the picture has activity limitations and performance restriction in moving around, washing, and education. Moving around has a first qualifier of 4, meaning there is a complete impairment, and a second qualifier of 4, meaning there is aberrant dimensions present. Washing has a first qualifier of 3, meaning there is a severe impairment, and second qualifier of 3, meaning there is an additional part affected. Lastly, education around has a first qualifier for, meaning there's a complete impairment, and second qualifier for, meaning there's aberrant dimensions present. The individual on the right of the picture, on the other hand, has almost fully functional, moderate participation in higher restriction. Higher education has a first qualifier of 0, meaning there is no impairment, and second qualifier of 3, meaning there is an additional part affected. The use of ICF properly determined the actual status of patients, like in this case, having been classified under B24, but have different ICF classifications. We now go to code example number 2. We have two patients, Ms. Harris and Ms. Brown, both diagnosed with multiple sclerosis, classified as G35 under ICD-10. Ms. Harris is a faculty member working over 40 hours a week. She is also a single mother to her 16-year-old daughter. She helps her daughter in search for college, while she needs help with dressing. She is a user of a power wheelchair and can use other equipments to move around. On the other hand, Ms. Brown has an early diagnosis and has stopped working ever since. She is a mother to a child living with other family members. She is under the constant supervision of an institution and unable to speak or eat anymore. Using the classification of ICF, we can see that these two patients have the same activities but with different extent of impairments. For activity of dressing, both patients have first qualifier of 4, meaning there is a complete impairment, and second qualifier of 4, meaning there's aberrant dimensions present. For independent moving around, Ms. Harris has first qualifier of 1, meaning only with mild impairment, and second qualifier of 4, meaning there is aberrant dimensions present. For independent moving around, Ms. Brown has first qualifier of 4, meaning complete impairment, and second qualifier of 4, meaning there is aberrant dimensions present. For job as an activity, Ms. Harris has a first qualifier of 0, meaning there are no impairment present, while Ms. Brown has a first qualifier of 4, meaning complete impairment is present. For being a parent as an activity, Ms. Harris has a first qualifier of 0 again, meaning no impairment present, while Ms. Brown has a first qualifier of 4, meaning complete impairment is present. ICF has 194 member states that uses this for research, surveillance, and reporting. ICF was also developed and published in 6 official languages, including English, Spanish, French, Chinese, Arabic, and Russian. License and distribution, full version and short version, public access on the internet is available, and electronic versions are also available. Below are the references used in producing this video.